Hello again, welcome to RX class. My name is Dr. Guang Chen, your host. My apologies, I haven't been recording as frequently. Life has been a little bit busy from both a family and professional point of view, but I'm back for 2025. Today, I'd like to discuss a topic which is a very a very common source of referral to my to my gastroenterology practice. I see a patient with this probably. I see several patients per week, and that is a case of Helicobacter pylori infection. Um, I think it's a good time to discuss this at this stage because the American College of Gastroenterologists did update their guidelines late 2024. And there's been some major changes in terms of some of the recommendations. I'd encourage anyone who might be interested to Google the American College of Gastroenterology Helicobacter pylori guidelines. Please note that throughout the podcast episode, the information presented is general in nature and use your own risk. Complex concepts may be oversimplified for entertainment purposes. Symptoms and medical conditions, as well as the diagnosis and treatment of these conditions, may be mentioned. The information presented does not constitute the practice of medicine nor replace medical advice from a licensed medical professional. Do not rely on the information to make decisions about your or someone else's health. Please seek help from a certified health practitioner if you have concerns or symptoms. So let's start with Helicobacter pylori. It's a very interesting story, both from a scientific and medical research perspective, as well as its current management. So the story started in the 70s, and Dr. Barry Marshall and Dr. Robin Warren were awarded the Nobel Prize for Medicine in 2005. But much of their work, as well as the work of many other collaborators, started in the 1970s and 80s. Just to paint the picture, up until the 1970s, it was thought that the stomach and the environment within the stomach was incompatible with any kind of living organism, such as bacteria. And so the environment within the stomach was thought to be sterile. There had been cases where certain bacteria had been photographed or identified within the stomach, but it was largely thought that these bacteria were transient and couldn't survive long term. And at the time, it was somewhat supported by some of the anatomical pathology samples that were received from major operations. And it was at the time, it was not known, but it was later thought that the reason that bacteria weren't discovered was because the samples had deteriorated so quickly before the samples were ultimately made into specimens. Now, what had changed was that in the 70s and 80s, there was a dramatic change in technology and in several different fields. In particular, for example, within gastroenterology, the video endoscope was coming into being. Prior to the 1970s, the endoscope was rigid, which means that it wasn't flexible. It didn't move around corners, and the viewing was often through the scope and not at a monitor. But in the 1960s and 70s, fiber optics were essentially being able to be incorporated into the scopes, which allowed the flexibility, and you could go down the upper gastrointestinal tract. And then also around that time, the development of various sensors allowed the images to be projected to a large screen. And so it was the image quality improved, and also the specialists could see more when they were doing the endoscopes. Other changes also occurred around the time, and that included the improvement in anatomical pathology specimen preparations. There were a number of dyes that had been developed, and so specimens could be essentially embalmed or prepared quickly, and the specimen and all the features could be preserved and highlighted with more detail. And so we go back to the story of Dr. Barry Marshall and Dr. Robin Warren. At the time, Dr. Marshall was a physician or physician trainee, and Dr. Warren was an anatomical pathologist, and both of them had been working in a hospital in Perth. And at the time, Dr. Warren, again, through a number of samples that were obtained from upper GI gastrointestinal endoscopy of patients who had biopsies and also especially patients who had gastric ulcers. And from there, he noticed that there was what looked like bacteria on the surface of these samples. And at the time, these bacteria appeared to look like another family of bacteria known as Campylobacter. And so these group of organisms were known as Campylobacter-like organisms, or CLO. At the same time, Dr. Marshall was working in the same hospital, and he'd been working in the gastroenterology department. And essentially, The story, which is worth reading about, is highlighted in the Nobel website, as well as many other documentaries, and I highly recommend delving into it if you want more detail. And as a side, the Nobel website is also very good for other information. There are detailed biographies, videos, and as well as accounts of stories like Dr. Marshall and Dr. Warren. So, long story short, Dr. Marshall and Dr. Warren eventually was able to isolate and grow this particular bacteria. And again, it was an interesting mishap, I guess, in medicine. Typically at the time, I think most of the cultures would be prepared and grown for 24, 48 hours. And typically after that, if nothing grew, it'd be thrown away. And to my understanding, on one particular weekend, I think the laboratory was busy or something had happened, and they had left the samples there unattended for several days. And that's when the bacteria did eventually grow. And so that was one contribution, that they were able to isolate and culture grow this particular bacteria. And then the second contribution was that Dr. Marshall was later able to show that a person could be infected with this bacteria, and then ultimately it did cause inflammation within the stomach, also known as gastritis, and that if treatment was given, such as an antibiotic regimen, it would also improve the inflammation and then ultimately prevent the complications of the bacteria. So that's the story of Dr. Marshall and Dr. Warren. Their story continues later on in terms of that they were also very crucial in the development of the current day diagnostic tests for Helicobacter, which we'll talk about later, but in particular the CLO test and also the urease breath test. Perhaps a little bit more about the bacteria itself. The Helicobacter pylori is a very small bacteria. It's only a few microns. And it actually is rod-shaped, or actually more screw-like, and it's got a number of tails known as flagella. The exact modality of infection is somewhat contentious, but the bacteria has been identified in infected individuals within their saliva, within their gastric juices, and also within their feces or stools. A number of theories exist in terms of how the bacteria infects others. Now, what is known is that the majority of people get infected in childhood, possibly less than the age of 5. And in actual fact, the risk of getting infected as an adult is reasonably low. And some studies quote maybe 1 in 10 or 1 in 100, and depending on multiple factors. Look, my personal theory is perhaps that the reason why children get infected is their immune system may not be as developed, and the actual overall stomach hasn't developed, and the amount of gastric juice perhaps or gastric acid is not as potent as an adult. Speaking about the prevalence, depending on which region of the world where you grow up, the prevalence can be as high as 80-90% of the population, but within the Western world, I guess if you can consider North America, Australia, European Union and United Kingdom, probably around 30% in general, slightly lower in certain populations and higher in other ethnic populations within the countries. And what is unique about the Helicobacter bacteria, number of interesting facts. It's actually the only bacteria that is listed as a carcinogen by the World Health Organization. It's the only bacteria that can live within the mammalian, in particular, I guess, the human stomach. There has been other Helicobacter species identified in other mammals. Now, what is unique about this bacteria is that there are 3 or 4 different there are 3 or 4 elements that allow the bacteria to thrive and survive within the stomach. And the first is urease. So the bacteria produces an enzyme known as urease, and urease converts a chemical known as urea to ammonia and bicarbonate. And this is important for the initial survival of the bacteria when it's within the gastric acid or the gastric or within the stomach center, because without this urease, the bacteria would be killed by the stomach acid, and with the urease, it protects itself from the surrounding acid. If it survives, then the flagella or the tails then push the bacteria to the edge of the stomach, and if it reaches the surface of the stomach, then it produces certain chemicals known as adhesins, or they're basically sticky chemicals that allows it to adhere or stick to the wall of the stomach. And then from there, certain chemicals known as cytotoxins are produced by the bacteria to irritate the lining of the stomach cells. And as a result, from that inflammation, nutrients are released from these cells, which the bacteria then feed off. And this goes on ongoing cycle, the bacteria produces, and then it can migrate or move to other parts of the stomach. Now, the cytotoxins have been associated with changes in genetic material, affect and also increase the risk of cancer. And so these are the predominant reasons why Helicobacter has been classified as a carcinogen. The cancers that it's associated with include gastric cancer or stomach cancer, as well as a specialized lymphoma called multiple lymphoma, which occurs within the stomach itself. Other complications include the effects on the lining of the stomach, and because it's affecting or it's constantly irritating the lining of the stomach, it's unable to heal. And when you have an unhealing wound, that's known as an ulcer. So Helicobacter has been strongly associated with the formation of gastric ulcers as well as duodenal ulcers. The diagnosis of Helicobacter infection, there are different ways of diagnosing the bacteria. There are some direct ways of detecting bacteria versus some indirect ways. So the direct way is to look at the bacteria under the microscope, and so that may be taken at the time of endoscopy and biopsy samples. We may detect bacteria using a urease breath test, which is a balloon-based test that uses a little bit of radioactive carbon, and we measure the activity of urease. And if it is elevated, then it suggests that there is bacterial infection. Other samples, including stool samples, are also possible, as Helicobacter is excreted in the stools. An indirect way of measuring Helicobacter is through the use of serology, or that's to measure the immune response to the bacteria. Unfortunately, that particular test isn't good at detecting current bacterial infection, but it typically shows them prior exposure. In terms of testing for the Helicobacter infection, depending on which part of the world and your risk factors, it is slightly different. Personal experience, the patients that I really would like to know their Helicobacter status would be any patient who may have a complication or who may be at risk of the complications. And so that includes patients who have a strong family history of, say, stomach cancer or stomach ulcers, any other patients that may be at risk of having gastric ulcers, such as patients who might be on non-steroidal anti-inflammatories, on aspirin. And that there are a number of other patients that, depending on circumstances, I would also encourage to have Helicobacter further testing. With these categories, it's highlighted within the American College of Gastroenterology guidelines, as well as many other guidelines. So I won't go through all of them. Once we've identified Helicobacter, the question is whether eradication is appropriate. And look, in most cases, eradication therapy would be recommended, as the current treatments are reasonably safe and well tolerated. Look, just as a history, at the time of Dr. Marshall and Dr. Warren, the initial treatments used the combination of bismuth and metronidazole. The effectiveness was not fantastic. It was later discovered that to improve the eradication, we really need to suppress the acid production within the stomach itself. And this is thought to be because at higher pHs or low acidity, the bacteria go into a reproductive state. As a result, they may be more sensitive to the antibacterials or the antibiotics, and then also they start producing more bacteria, and as a result, there's a high chance of eradicating all bacteria. And up until recently, the standard of care for Helicobacter eradication is a combination of a proton pump inhibitor, which is an antacid or anti-reflux medication, with a combination of one or more antibiotics. And that's what's currently available in Australia here. The approved combination is a combination of esomeprazole, amoxicillin, and clarithromycin. Now, what has been different in North America and also in other parts of the world, such as Southeast Asia and Japan, has been the new medication known as vonoprazan. So vonoprazan is a medication that is a first-in-class. It's part of a class of medications known as potassium-competitive acid blockers. They target a different pathway in terms of acid production within the stomach. Vonoprazan and PCABs as a class appears to be much more potent in terms of acid suppression compared to our standard proton pump inhibitors, as well as the onset of action is also more rapid. And within the new the new American College of Gastroenterology guidelines, in addition to the quadruple therapy, vonoprazan plus amoxicillin or vonoprazan plus amoxicillin and clarithromycin have been recommended as treatment options. And this is a major change compared to previous guidelines. Unfortunately, in Australia, vonoprazan is unavailable, but I'm hopeful that perhaps it will receive approval in the coming years. It has been available in the United States since last year after FDA approval for both Helicobacter eradication as well as reflux treatment. I'm especially excited because I do have several patients where various combinations of Helicobacter eradication hasn't been successful, and I'm hopeful that perhaps vonoprazan may offer additional opportunity for us to eradicate. Again, thank you for listening. I hope this episode has been helpful. Look, if you'd like to discuss more or have questions about Helicobacter, please send me some feedback online. What I haven't discussed today, and perhaps another topic of another episode, there are some associations with its effects on the immune system and perhaps reducing childhood allergies. There are also associations with reduced gastric acid production and perhaps the reduction of esophageal cancer.